Welcome everyone to our panel discussion on preimplantation genetic testing. Preimplantation genetic testing is a crucial screening method used during in vitro fertilization to assess embryos for genetic disorders or chromosomal abnormalities before implantation. By analyzing a few cells from embryo, PGT helps select embryos with normal chromosome number or to detect specific genetic conditions. This proactive approach enhances the likelihood of successful pregnancy by minimizing the risk of implanting embryos with genetic defects, thus potentially reducing miscarriages rates and improving the overall success of IVF cycles, especially for older women or couples with history of genetic diseases or recurrent miscarriages due to chromosomal abnormalities. Our panelists for today's discussions are Dr. Bibhas, Consultant and HOD, Department of Genetics and Molecular Medicine, Kokilabai Dinobhai Ambani Hospital and Medical Research Institute. Dr. Bibhas has a distinguished career in the hospital and healthcare industry. Dr. Bibhas is skilled in clinical research, medical education, life sciences, oncology, and medicine, and holds a PhD degree in life sciences genetics from Utkal University. He is also a member of various scientific societies and serves as an advisory member on the educational editorial boards of several scientific journals. Dr. Deepak Modi, Scientist G and Head, Molecular and Cellular Biology Laboratory, ICMR, National Institute of Research in Reproductive and Child Health. As the head of a cutting-edge laboratory, Dr. Deepak's research focuses on the fundamental mechanism of embryo implantation, early placentation, and the molecular basis of gonad development. Dr. Modi's work is important in understanding how these processes are disrupted in women with infertility. A passionate advocate for exploring the biological basis of sexuality and gender, he is also a renowned TEDx speaker. Dr. Sneha Sathe, Clinical Director and IVF Specialist, NOAA IVF Fertility. Dr. Sneha Sathe has extensive experience as a gynecologist and fertility specialist. She has a proven track record in the hospital and healthcare industry. Dr. Sathe is highly skilled in reproductive endocrinology, infertility, and in vitro fertilization, holding a master's degree in obs and gynae from Kasturba Medical College, Bangalore. Welcome our panelists.
Thank you. Thanks for your nice introduction.
Thank you so much.
Thank you. So to begin with, my first question is to Dr. Bibhas. What considerations guide your selection between PGTM, PGTA, and PGT-SR for different genetic conditions, and how do you explain these options to patients?
See, Dr. Manisha, for this prenatal genetic, pre-implantation genetic testing has emerged as a revolutionized technique in the field of reproductive medicine. And PGT is the process of screening embryo produced during in vitro fertilization for genetic diseases and chromosomal disorders before they are transferred to the women's uterus. Now, the PGT thus provide a very, informative information or accurate informations and about embryo's health. Therefore, it helps to choose the best embryo and reducing the risk of transmitting genetic diseases and increasing the chance of live birth. Now there are three tests that we do in the diagnostic setup.
Yes.
So the test that is conducted is the PGT-A, PGT-SR, and PGT-M. Now I'll explain one after the other, one by one. Now PGT-M, it is about the monogenic conditions or monogenic diseases where we deal with autosomal recessive conditions, autosomal dominant and X-linked mainly. And it is recommended for couples at risk of transmitting a specific genetic condition caused by single gene mutation. And this includes autosomal dominant, as I explained, autosomal recessive and X-linked recessive disorder. And the process involves identifying the mutation in parental DNA and subsequently screening the embryos for the same mutation. Now, what is PGTA? So, according to the clinical setup and condition and requirement, we need to decide what is required for the patient. So, PGTA is an aneuploidy conditions we see where we focus on detecting the numerical chromosome abnormalities such as trisomies or monosomies, which are common causes of implantation failure, miscarriages, congenital conditions, and it is particularly beneficial for patients with advanced maternal age, recurrent pregnancy loss, or multiple IVF failures. Now, coming to structural abnormalities, which detect the chromosomal structural, balance translocations or kind of inversion and deletion. Now, this test is very crucial for individuals known to carry balanced chromosomal rearrangements, which can result in unbalanced gametes. So there will be a 50% unbalanced gamete, partial monosomy, partial trisomy. So these kind of things, and a balanced like parents. So which leads to infertility or miscarriages. So I think this is what I can highlight on this.
Right. So my next question is to Dr. Deepak Modi. Can you detail the procedure and anatomical consideration of performing a trophectoderm biopsy versus blastomere biopsy in PGT?
So historically, when PGT started, where you wanted to detect these abnormalities, it started with a blastomere biopsy, which was done at 8-cell stage, where one cell of that was taken out, and then you would do a FISH technology typically there and count the numbers of chromosomes. This is limited to 3 to 5 chromosomes. However, this did not allow now looking at the entire chromosome complement. So over the years, when the blastocyst culture became better, we could make more and more blastocysts. The entire PGTA business shifted to a trophectoderm biopsy. So trophectoderm is the outer layer of the embryo, where you would remove a few cells from that and subject it to either a next generation sequencing or to a PCR, depending on the PGTA or PGT-SR that you would want to do, or PGTM, you would subject it to the technique. So the trophectoderm biopsy is the one which is now currently the gold standard for performing PGTA. Blastomere biopsies are not in vogue, neither they're in vogue, neither they are recommended, except for if you want to do some PGT-SR, which could be only done by FISH, you may want to consider it. But blastomere biopsies, trophectoderm biopsies at the blastocyst stage are the ones which are strongly recommended for any PGT program.
Right, right. So, Dr. Sneha, how do you use the data obtained from PGT to select the best embryo for transfer?
So actually, it depends on which type of PGT we are doing and for what indication we are doing the PGT. It could be PGT-A, PGT-M, or PGT-SR. With PGT-A, the idea is that of the total number of blastocysts that you have, which one is euploid? We can only know the chromosome number. So let's say there are 5 blastocysts. Out of those 5, maybe 1 or 2 are euploid, or maybe 3 are euploid. So we have to choose any 1 or 2 maximum embryos out of the ones that are euploid. So of the euploid embryos, some labs give something called as mitoscore, which again, if an embryo is euploid, we can choose which of those euploid embryos is the better one for transfer. So an embryo with a lower mitoscore has probably a little higher chance of having a successful implantation. For PGT-M, the idea is to choose an embryo which is free of a specific genetic condition that you are looking for, which either of or both of the parents are carriers, or maybe they have the genetic disorder. So the idea is to find the embryo which does not carry. It's like a negative selection. So very often when we are doing PGT-M, we also combine it with PGT-A. It shouldn't happen that the embryo doesn't have the genetic disorder, but it has aneuploidy. So we often do PGT-M with PGT-A and select an embryo which is euploid and which is free of the specific genetic disorder. And the third one, of course, is PGT-SR, which is for structural rearrangement. We choose the embryo which does not carry, for example, a translocation. So choosing an embryo which is free of the specific genetic disorder that you're looking for improves the chance of having a successful implantation, reduces the risk of having a miscarriage, and increases the chances of having a successful life birth.
Right, right. So, Dr. Bibhaskar, how do you ensure the accuracy and reliability of PGT results, especially in detecting mosaicism and other complex genetic variations?
See, there are a lot of advanced technology now available, like NGS, array-based, comparative genome hybridizations, and which ensures high resolutions and accuracy. And in detecting chromosomal and genetic anomalies. And to enhance the accuracy of detecting mosaicism where more than one cell line is present in the embryo, multiple biopsies can be taken from different embryonic cells. And advanced bioinformatic tools are now being utilized, which can be used, and for interpreting the complex genetic conditions or variations, rather. So rigorous quality control measures are also available, including validations protocol, use of control samples, proficiency testing, which are very essential otherwise also. And laboratories, those who practice such PGT technology or the diagnostic PGT techniques, they adhere to stringent, protocol for DNA amplifications, analysis, which further ensures your reliable results.
Right. So, Dr. Deepak, what are the considerations for determining the optimal timing of embryo biopsy, for example, cleavage stage or blastocyst stage for PGT?
So as I said, cleavage stage is not recommended as of today. Blastocyst stage is the one which is definitely recommended. Of course, that comes with a rider that you should have enough numbers of blastocysts. And as sir mentioned, that the risk of mosaicism, the proportion of mosaicism in a cleavage stage is more than what you would see the blastocyst stage. So blastocyst stage is the recommended stage for biopsy.
Correct. So, Dr. Sneha, what markers of uterine receptivity influence the timing and procedure of embryo transfer after PGT?
Generally speaking, for PGT embryos, it is always a frozen embryo transfer. For a frozen embryo transfer, there are different ways to prepare the endometrial lining. One way is to give the woman estrogen tablets from the second day of her period and monitor the lining by serial ultrasound. We check the lining for its thickness, for the trilaminar appearance, and whether the Doppler flows are good. And when the lining appears, endometrial lining appears good, that is the day we check her progesterone level. And if the progesterone level is low, below a specific cutoff, you add progesterone medication for her and plan the embryo transfer as a blastocyst transfer. So day 5 after starting the progesterone medication. The other way to prepare the endometrial lining is to monitor a natural cycle. So for a woman in a natural cycle, as the follicle grows on its own, there are natural hormonal changes in the body, and the natural estrogen leads to improvement in the endometrial lining. But for the natural cycle embryo transfer, we have to monitor follicle rupture. And based on the day of ovulation, we need to decide the day of the embryo transfer. So this natural cycle transfer is not possible for women with polycystic ovaries because they don't ovulate. So for such women, we might need to give them mild stimulation to maybe grow just 1 or 2 follicles. And as the follicle grows, naturally the endometrial lining develops, and we plan transfer after giving a trigger injection for follicle rupture. So for planning an embryo transfer in a frozen cycle, whether it is for PGT embryos or non-PGT embryos, essentially the principles are the same.
Yeah, right. So, Dr. Bibhaskar, can you describe the challenges and advancements in identifying and interpreting chromosomal abnormalities, for example, aneuploidy, structural rearrangement during PGT-A and PGT-SR both?
The primary challenges in identifying and interpreting chromosomal abnormalities during PGT-A and PGT-SR, it includes accurately detecting mosaicism. So that is a big, area. I mean, very, difficult area. Differentiating between technical artifact and true genetic abnormalities, and interpreting the clinical significance of detected variants. So advancement in single cell sequencing technologies and improvements in bioinformatics algorithm have significantly enhanced the resolution part and accuracy part of PGTA and PGTSR. But here I will just a little, differ in one. I will not differ, but non-invasive prenatal screening, this method are being developed such a way to reduce the risk associated with embryo biopsy, providing a less invasive option for genetic testing.
Right.
So could be that will be one area. Even many times, wherever there is a doubts, we do it through prenatal genetic testing.
Right.
Even if they have gone through all the technologies, whether PGTA, Dr. Sathe will agree with me, even we confirm through prenatal genetic testing.
Correct. Correct. So, Dr. Deepak,
When we
what
have done
say?
PGT, actually, we always counsel the couples that even though we have done PGT, your embryo is normal, high risk screening during pregnancy is still important.
Correct. I agree. Right. So, Dr. Deepak, what cellular structures and genetic material are specifically targeted during biopsy for PGTM, PGTA, and PGT-SR?
Sure. So just before I answer this question, I'll add on to Dr. Sathe's question that Sathe's point, and sorry, Dr. Bibhaska's points on mosaicism, that beyond the way of validating it, currently a lot of people are also developing AI-based tools. So when you have the results from a PGTA lab, they are also subjected to AI, especially in cases of mosaicism, to allow you to discriminate whether this is true mosaicism or can we worry about it or we need not. That's one. And number two, also a lot of international societies give a scoring system to the clinicians. I'm sure Dr. Sathe will agree to it. That they even give you a score that, okay, this is a transferable embryo. These are mosaic but non-transferable. These are mosaic plus transferable. So increasingly, we are getting better and better at our ability to get to the accuracy of the testing. Getting to the point of which cellular structures are used, of course, in our, whether it's PGTA or PGTA-SR or PGT-M, we always target the trophectoderm, which is the outermost layer, which is what we call it is the extra embryonic tissue, because the blastocyst differentiate between inner cell mass and trophectoderm. Trophectoderm goes to form the placenta. So the point is we are not looking at inner cell mass in any of these biopsies. So this is some people, they do raise an objection that you're not really testing the actual embryo. You're looking at the trophectoderm, which is going to be from the placenta. But as a developmental biologist, I assure you that at this point, no such segregation happens, and the abnormal cells only go to trophectoderm and the normal cells and the cell mass or vice versa. There are a few exceptions to this, but these hypotheses have never been validated. As of today, most of the trophectoderm-based biopsies done have yielded very concordant results with what is seen in the fetus.
Right. So, Dr. Sneha, how do you monitor and assess the development of ovarian follicles during the stimulation phase for IVF with PGT?
So when we are planning ovarian stimulation for IVF, whether it is PGT or non-PGT, the principles remain the same.
Yeah.
But in PGT, we are more, there is a lot more at stake. So we tend to be a lot more careful. Whenever planning a stimulation protocol, there is no one size fits all in IVF. We have to individualize, and this individualization happens at many steps, right? From protocol selection to selection of dose, selection of drug, selection of type of trigger, whether to do IVF or whether to do HC, whether to do a fresh transfer or frozen transfer. So we have to select at each step based on the couple's individual characteristics. The intention always in an IVF cycle is to have an optimal response. We want to avoid cycle cancellations. A woman with good reserve, we want her to grow as many follicles as she has. For a woman with poor egg reserve, we can't have an unrealistic expectation and can't expect that she will have many follicles growing. So for each woman or each couple, based on that particular couple's characteristics, we have to set expectations for the couple, particularly. In PGT specifically, we try to avoid poor response. Poor response will mean fewer eggs, will mean fewer embryos and fewer blastocysts, and a lower probability of probably having a genetically normal or a wanted type of embryo. So in PGT specifically, we try to make sure that the ovarian response is adequate, and the tendency is to cancel cyclation cycles if the response is not adequate.
Right. So, my next question is to Dr. Bibhaskar. How do you address patient concerns about the potential limitations and uncertainty of PGT results, such as false positive or false negatives?
It is always essential, to communicate transparently about the potential for false positive and false negative, as well as the limitation of the tests. So follow-up prenatal, diagnostic testing, as I said earlier, such as amniocentesis and coronary villi sampling, can help confirm PGT results and provide additional assurance. And not only that, we need to discussing the probabilities and implication of diagnostic errors helps manage patient expectations and reduce the anxiety part.
Right.
So by providing a clear evidence-based information, patient can always, make a kind of informed decisions about their reproductive options and potential outcomes.
Correct. So my next question is to Dr. Deepak, that how do you handle and interpret cases of embryo mosaicism detected during PGT, and what guidelines do you follow to make decision about transferring mosaic embryos?
So this has been one of the most controversial aspects of PGTA because typically we now see that although the rates of mosaicisms are reducing and are getting better and better with improvised technologies, but I'm sure Dr. Sathe will agree with me that there are enough numbers of patients where you have only mosaic embryos and you now don't know what to do. And these kinds of situations are difficult to handle both from the embryology side, from the clinical side, and the genetic lab side. However, the good news is that there are enough guidelines available now from various societies, including the American College of Medical Genetics, including ESHREs, ASRMs, which now clearly define that, okay, these are the kinds of mosaic embryos which you can transfer, and these are definitely known. And these guidelines are different societies giving different kinds of guidelines, but most of them work on the principle that, okay, if these are trisomies or monosomies, which are not lethal, which are going to come to live birth, then those mosaicisms definitely are not recommended for transfer because you don't want to give a trisomy 21 or a trisomy 18. Many of them are segmental aneuploidies, which are many of them dissolve over time. So it is permitted. Then they're also looking at the percentages that, okay, what proportion of cells are, so they call it as low-grade mosaicisms and high-grade mosaicism. And low-grade mosaicism, fewer abnormal cells are deemed for transfer over a high-grade. So, but the point is that each one of us, I would also urge all the diagnostic labs as well as clinicians and embryologists to constantly look for these guidelines because these are upgraded almost annually, depending on more and more that we are learning out of the knowledge that we get every time. So after every ESHRE meeting, typically in 6 months' time, they release a guideline, what is the updated status of mosaic embryo transfer. So there are various groups across the world who are working it. Unfortunately, in India, we do not have such a network where we learn from our things, but it is time that we as Indians also form a network so that we learn from our own experience what should be transferred, what should be transferred. We cannot say that we should not use the technology because we don't know what it does. It's rather look at it head on and see how better we can use it for patients.
Correct.
I think what is most important with a mosaic embryo is counseling and informed decision from the couple, and that becomes very tricky and very difficult, especially if the understanding level of the couple is low. So we need to, have a good group discussion on how we are going to counsel couples with only mosaic embryos.
Right. And Dr. Sneha, how do different types of PGT influence IVF outcomes, such as implantation rate, pregnancy rate, and live birth rates?
So with PGT, we are able to find healthy embryos for transfer, whether it is PGT-A or PGT-M or PGT-SR. Now, PGT-M does not improve implantation rates or does not improve pregnancy rates as such, but PGT-M helps the couple in having a child without that specific genetic disorder.
Yeah.
There may be genetic illness running in the family, So,
Correct.
this cycle of genetic illness in the family can be broken by PGTM. Once they have a child which is free of the genetic disease, the subsequent generations remain free of that particular genetic disease. But with PGTA and PGTSR, it is different. With PGTA, we are able to select a euploid embryo, an embryo with a normal chromosome number. And because we are able to choose a euploid embryo for transfer, automatically her chance of pregnancy improves and risk of miscarriage reduces and the chance of live birth increases. Similarly, with PGT-SR, again, we are able to choose embryos without a structural rearrangement. Women with translocations or couples with translocations have a higher risk of recurrent implantation failure or recurrent pregnancy loss. And hence, by PGT-SR, this can be avoided in that particular couple.
Right. So my concluding question would be to Dr. Vivaskar. Can you explain the role of genetic counseling in PGT process, particularly in helping patient understand their genetic risk and make informed decisions about embryo selections?
Genetic counseling actually plays a very crucial role. Forget about PGT, but on the whole, if you see our day-to-day practice, it is really very crucial part. It is a very critical and crucial. And when it comes to PGT process, the understanding their genetic risk based on family history and genetic testing results. So counselor assist in interpreting the PGT results, guide patients in making informed decisions about embryo selection, additionally providing emotional and psychological support, which are of course crucial as patients navigate, they go through this stress and anxiety associated with genetic testing and reproductive decision making. So therefore, genetic counseling ensures the patient are well informed, supported, empowered to make decisions that align with values and goals.
Yeah.
So not only that, we need to understand and respect patients, cultural, personal belief is essential for, providing effective genetic counseling. Also, we need to tailor the communication, tailoring the communication and counseling approach to align with the patient's values, their belief, their preferences, which facilitate a better understanding, rather, I should say, a decision making. And we should be open and honest, rather, to the patients while discussing and explaining various conditions we need to, take into considerations like ethical, cultural, and their personal implications of, PGT. It helps address concerns and misconceptions. So this approach fosters a supportive environment where patients feel understandable, patients feel understand and respected.
And not judged.
In their decision-making process.
Right. So with this whole discussion, I've got to know that we have got enough tools and they can make informed decisions and have healthy babies. So thank you, our panelists, for joining us. Thank you so much.